Dear students and fellow faculty, hello everyone. I'm Rajneesh Kumar Sharma from the Department of Prosthetics and Orthotics, Pandit Deendayal Upadhyaya National Institute for the Persons with Physical Disabilities. Would like to introduce Ms. Priyanka Chandra, our 13th batch student, who will make her presentation on the topic Congenital Talipes Equino Varus and Early Intervention. She'll detail you about the Ctv, its management, and early intervention for the children. I believe that the presentation so made by Ms. Priyanka Chandra will enhance the knowledge of the students at large. I expect that each of the students will attentively listen to the presentation and gain the knowledge as much as possible.
Good morning, respected faculties, my batchmates, all the participants and their students. My name is Priyanka Chandra and I am pursuing my internship from Pandit Deendayal Upadhyaya National Institute for the Persons with Physical Disabilities. First of all, I would like to thank our director, Mrs. Smita Jayavant ma'am, Mr. Rajneesh Kumar Sharma sir, Assistant Professor, Piano Department and my mentor, Mrs. Smita Nayak ma'am, Piano Demonstrator and my guide, and all the respected faculties for providing me the opportunity to be a part of this webinar today. I am sure you all know that our institute is soon opening an early intervention center to support the babies and toddlers from birth to 6 years of ages with developmental delays or disabilities. So a question will definitely rise in your mind. What is early intervention and why we need this in our institute? Early childhood intervention (ECI) is the process of providing specialized support and services for infants and young children with developmental delays or disabilities and their families in order to promote development, well-being and community participation. We will take a closer look at your child's skills, and our mission involves identifying children and families not may be at a risk of running into difficulties and will provide timely and effective support. Ctev is one of the poorly understood but common developmental disorder of the lower limb which affects at least 2 per 1000 Scotch birds as per the ISD data. So today my topic of presentation is Ctev and its early intervention. What we are going to discuss in this presentation is what is Ctev, what are the deformities involved in Ctev, its incidences, clinical features, etiology, how to examine the Ctev, what are the diagnosis and radiographic evaluation, and what are the treatments available for Ctev. We will discuss in detail. So as we already discussed that Ctev is one of the first deformity of children. So before moving to the topic, we will discuss some types of deformities so that it would be easier for everyone to connect or understand the deformities involved in Ctev, and you can imagine it easily that how it looks like. So as you can see in the picture, there are various types of deformities. So let's discuss it individually. The first deformity in the image is equinus. Equinus is a condition in which the upward bending motion of the ankle joint is limited. Someone with equinus lacks the flexibility to bring the top of the foot towards the front of the leg, and calcaneus is just opposite to it. Another image is the varus. A varus deformity is an excessive inward angulation or medial angulation, that is towards the body's midline of the distal segment of a bone or joint. The opposite of varus is called valgus. While cavus is a multiplanar foot deformity characterized by an abnormally high medial longitudinal arch, while planus is flat foot with no medial longitudinal arch. and the splay is a term used to denote the spreading of the metatarsal bones. So now we all are aware what are the deformities. Now it would be easier for us to connect these terms to the topic in the coming slides. Coming back to the topic of presentation, that is CTEV and its early intervention. What is CTEV and how it looks like? CTEV stands for Congenital Talipes Equino Varus, and the other and common name for CTEV is cleft foot. It is a birth defect in which the foot is twisted out of the shape or position and defined as the fixation of the foot in adduction, in supination and in varus, that is inclined inwards, axially rotated outwards and pointing downwards. CTEV is a small term, but it contains lot of deformities in itself, as C stands here for congenital, which means by birth. Tele is for ankle and pes is for foot. It means we can say that the deformity is involved in both ankle and the foot. And equinus we already discussed in the types of foot deformity slide. The common term used for equinus is foot drop, and varus is turning inward or excessive inward angulation, as we already discussed. Coming to the next slide, you can see a picture in this slide. This is a picture of a 2-year-old child who visited our institute in the last week of December, and he is suffering from CTEV. He had multiple surgeries in his foot. The last surgery was around 9 to 10 months ago. He visited our institute for the Dennis Brown splint and the 9 AFO splint. We will discuss it later about the splints and managements. And his casting was done, and he was then provided with the splints he was requiring a week later. So we were discussing about the deformities involved in CTEV. We have discussed that it contains a lot of deformities in itself, like equinus, varus and adduction, rotation and cavus. Take a closer look to this slide. There's a word written as cave. So we can say that cave is the word which contains all the clinical components involved in CTEV. C is for cavus, that is exaggerated medial longitudinal arch at mid-foot. A for adduction, that is forefoot will go into adduction at the tarso-metatarsal junction. And varus will take place at talonavicular joint, and we can say that in varus the hindfoot rotates inwards at talonavicular joint, and equinus is excessive plantar flexion, where the foot fixed in plantar flexion at the ankle joint. And so the deformities takes place at the respective joints. This image shows the division of foot in the 3 sections: forefoot, midfoot and hindfoot respectively. Now we can easily connect the deformities we discussed in the last slide involved in CTEV as per the foot region or the particular joint. Moving to the next slide, we should know the number of children affected by CTEV. So talking about the incidences, we have a data here which shows that about 1.19 children in 1000 lives birth get affected by the cleft foot, and most of the cases are sporadic. Cleft foot is more common in boys than girls, and 50% of cases of CTEV are bilateral, while if the case is unilateral, right side is more involved. Now we have a clear image of CTEV in our mind, like what is CTEV and how it looks like. Let's discuss some more points and its clinical features. We all know that in CTEV the foot turns inwards and the heel goes in equinus. But do we know the size of the heel? The heel is small in size. And you can also find deep creases on the medial and posterior aspect of the foot and can feel the tightness in calf muscles. The calves are usually abnormal and thin. The range of motion of the joints gets decreased, and you can feel a varying degree of resistance when you try to dorsiflex and evert the foot. So if your child is having all these problems, consult a doctor soon. Don't delay, as you know all the features of the CTEV now. But why CTEV develops? What are the causes? Discussing the etiologies of CTEV, we will get to know that there are some unknown causes related to some theories, while we have some underlying causes associated with secondary CTEV. On this basis, we have two categories held responsible for CTEV, that is idiopathic and secondary CTEV associated with underlying cause. Several theories have been proposed to explain the origin of clubfoot, considering both intrinsic and extrinsic causes. Some of the theories are mechanical theory, ischemic theory and genetic theory, including intrauterine position of the fetus, mechanical compression or increased hydraulic pressure, interruption in fetal development, viral infections, vascular deficiencies, muscular alterations, neurological alterations, defect in the development of the bones structure and genetic defects. So the mechanical theory states that due to raised intrauterine pressure, it forces the foot against the wall of the uterus in the position of the deformity. While as per the ischemic theory, if there is ischemia of the calf muscles during the intrauterine life due to some unknown factor, it results in the contracture which leads to the foot deformities. While as per the genetic theory, some genetically related disturbances in the development of the foot have been held responsible for the deformity. Now coming to the secondary clubfoot, what are the possible causes of secondary clubfoot? So we have some causes, that is paralytic disorder and arthrogryposis multiplex congenita. In paralytic disorder, due to the muscle imbalance, an equinovarus deformity develops. That is, in this, the inverters and plantar flexors are stronger than the everters and dorsiflexors. Another cause for secondary clubfoot is arthrogryposis multiplex congenita, AMC, which refers to the development of multiple joint contractures affecting two or more areas of the body prior to birth. It results in the thin, weak, stiff or missing muscles and stiff joints due to extra tissues like fibrosis or fibrous ankylosis, and one can see the differences in the skin around their joints such as webbing. How to examine a CTEV foot? All we know the characteristics of a clubfoot, so physical appearance is one of the greatest examination here. Normally the foot of a newborn child can be dorsiflexed until the dorsum touches the anterior aspect of the shin of the tibia. So this is a good screening test for detecting the milder variety of clubfoot. As the heel is small in size, the calcaneum may be felt with great difficulty. One can find deep skin creases easily on the back of the heel and on the medial side of the sole. Also, bony prominences can be felt on the lateral side of the foot, the head of the talus and lateral malleus. Outer side of the foot is gently convex and there are dimples on the outer aspect of the ankle. If there is an attempted correction, we can feel the tight structures posteriorly, that is at tendoachilles, and plantar warts, that is at plantar fascia. After foot examination, we will go through the detailed radiographic evaluation. If the child is non-ambulatory and has not started to walk yet, we will consider the anteroposterior, anterior posterior and stress dorsiflexion lateral view, while if the patient can walk or an older child, then standing anterior posterior and standing lateral views are considered. These are some of the important angles we need to measure: talocalcaneal angle on anterior posterior and lateral view, tibiocalcaneal angle on lateral view, and talus first metatarsal angle. What will be the radiological findings? the normal talocalcaneal angle is 35 to 50 degree, but in club foot we will find a decreased talocalcaneal angle and disrupted talar first metatarsal angle in the lateral view. Along with this, we can see that the long axis of talus and calcaneum passes inferior to the cuboid, while normally it crosses cuboid. On anterior posterior view, we will find an increased talocalcaneal angle and increased talar first metatarsal angle. Long axis of talus deviate laterally and passes along third or fourth metatarsal bone. Also, the diagnosis is easy in the cases presenting soon after birth. In those presenting late, secondary cause of Talipes Equino Varus deformity must be excluded. That is why early intervention of CTEV is must required. X-rays of the foot are done, anterior, posterior and lateral view, with the foot in whatever corrected position is possible. And the talocalcaneal angle in a normal foot are more than 35 degree, but in CTEV these are reduced. Once the diagnosis is completed, we move to the prescription and treatment of the club foot. But before proceeding to the treatment, we must have a goal and plan for the treatment, and there are some principles related to it also. The main goal of the CTEV treatment is to achieve a flexible and a plantigrade foot and cosmetically acceptable, functional and pain-free foot in shortest treatment time. What are the principles of treatment for CTEV? It is to release the soft tissue contracture or stretching to restore normal tarsal relationship. Once the normal tarsal relation is attended, correction should be maintained till tarsal bones remold stable articular surface. So we have a detailed treatment plan for CTEV. You can see in the picture there is a flow chart. First of all, examination should be ruled out the neuromuscular causes, which we have discussed above. If it is an idiopathic club foot, we should know whether it is a fresh case, that is soon after the birth, or an old or neglected case. If the case is fresh, then Ponziti method of serial casting is applied for 2 to 3 weeks. After then we proceed for the percutaneous tenotomy of tendo Achilles. If the correction is achieved, then the foot is maintained in Dennis Brown splint till 1.5 years, and then follow-up will be done for 10 to 12 years. One can see the progress as well. But if the correction is not achieved after percutaneous tenotomy of tendo Achilles till 4 to 6 months, then depending upon the type of deformity left, surgeries are done. Same will be considered in an old and neglected case as per the level of deformity. So here's a treatment chart available as per the category. We have divided it in the parts like non-operative, operative or surgical, and the rehabilitative managements available for CTEV. So we have Ponziti Technique, Kite and French technique in non-operative treatment, and there are so many surgeries also like posterior medial soft tissue release, osteotomies, triple arthrodesis, Achilles tendon lengthening, and the rehabilitative management includes splinting and the physiotherapy. So here's the conservative treatment of club foot. So it is divided into passive movements and the active movements. Passive movement is followed by gentle passive stretching and stretching to posterior medial tight structures, while active movement should be encouraged during the therapy itself, which is given 3 to 4 times a day for a few minutes each time. Between the active and passive movements, the foot and leg are stroked and massaged. After each procedure, the foot is immobilized by means of a soft bandage in the corrected position attended. In the newborn, the mother is taught to manipulate the foot. When the child attains the age of 3 months, manipulation of foot will be done once in 2 weeks. Foot is held in corrected position by strapping with a plaster cast. The cast must be extended till above the knee. Along with the physiotherapy, braces are also prescribed, and there are so many non-surgical techniques available for the treatment of CTEV. When conservative treatment proves ineffective, surgical treatments are done. Kite method. This method consists in conservative treatment with cast by gradual gentle manipulation performed every 7 to 14 days. Correction of each component or each deformity is done separately and in order. The cast is placed below the knee in the first 2 to 3 sessions, then made passage of cast over the knee. Treatment duration is approximately 6 months, and at the end of the first 3 months of treatment, Achilles tenotomy is performed. Then again placed for 3 months in plaster by changing it every 2 to 3 weeks. When treatment ends, family members are taught about exercising foot and keeping Dennis Brown splint. So here is the order of treatment. Which deformity we treat first? First, forefoot adduction is treated. Then we will go to the heel varus correction, and after that equinus is treated. Now the Ponziti technique. In this technique, this is accomplished with a percutaneous surgical release of the tendon, which allows the ankle to be positioned at a right angle with the leg. A total of 5 or 6 casts are typically needed to correct the foot and ankle. More are needed in the most severe cases of club foot. The corrective process utilizing the Ponziti technique can be divided into 2 phases: the treatment phase and the maintenance phase. The treatment phase is the phase during which time the deformity is corrected, while the maintenance phase is that phase during which time a brace is utilized to prevent recurrence. The Ponziti method treatment of club foot includes gentle manipulation and stretching, and it contains a series of precisely applied plaster cast. Most of the cases go through with percutaneous tenotomy, and the braces can be worn while sleeping up to the age of 4. But as per the various studies, we get to know that Ponziti technique provides rate of reduction of hindfoot and midfoot deformity is higher with Ponziti method as compared to kite method. This slide shows a number of surgeries available as per the requirement of the patient. These are tendo-Achilles lengthening and posterior capsulotomy, posterior medial soft tissue release, and complete subtalar release and bone operations. Now coming to the next slide, we will discuss about the French technique, and then we will discuss the orthosis available for the correction of CTEV. So what is French technique? The French technique or method, also known as functional physical therapy method, is a combination of physiotherapy, splinting and surgery. It consists of daily manipulations of the new bones, clubfoot, by a specialized physical therapist, stimulation of the muscles around the foot, and temporary immobilization of the foot with elastic and non-elastic adhesive taping. The French method reduces but does not eliminate the need for many invasive surgical procedures. Equinus is the most difficult deformity to treat. Posterior release is sometimes necessary in a severe foot. However, regular manipulation and splinting improve foot morphology and stiffness, and ultimately make surgery easier and less extensive. Now coming to the orthotic management of the club foot. We were discussing before that splinting can improve the foot morphology, but what are the splints, how do they work, and what are the types available? So Ctv splints are the splints made of plastic molded in such a way that when tied with straps, it keeps the foot in corrected position. So some of the splints are Noah splint, Dennis Brown splint, and Ctv shoes are also provided. So Dennis Brown splint. Dennis Brown splint is one of the Ctv splint, commonly known as DB splint. The Dennis Brown splint It is also known as Dennis-Browne bar or foot abduction orthosis and is used in the treatment of club foot. It is attached to the corrective shoes to maintain proper hip and foot position. The adjustable rotation allows for desirable external and internal rotate. It composed of a curved bar attached to the sole of a pair of the shoes. External rotation is adjusted by butterfly nuts on sole. The shoes mounted on the crossbar is in the position of 70-degree external rotation and 15-degree dorsiflexion. Distance between shoes is set at about 1 inch wider than the width of infant's shoulder. In unilateral cases, normal foot should be in 40-degree outward rotation. It is used throughout the day before child starts walking. Once the child starts walking, a Dennis-Browne splint is used at night and Ctv shoes during the day. Dennis-Browne splint is used after successful correction of deformity to prevent relapse. In this image, you can see the Dennis-Browne splint. The bar is attached to the shoes. That is the Dennis-Browne bar. Now coming to this slide, we have an image here. There are two different angles written and about the foot positioning. One is for normal foot and the other is for the Ctev foot. It shows that the Ctev foot is capped in 60 to 70 degree abduction, which we have discussed in the previous slide, while the normal foot positioning is in 30 to 40 degree foot abduction. Now we have the Ctv shoes for the treatment of club foot. Ctv shoes are the modified shoes which are used when the child starts walking, but its features are different from normal shoes. The inner border of the shoes is straight to prevent the forefoot adduction, while we provide outer shoe raise to prevent the foot inversion, and no heel is given in the shoes to prevent the equinus deformity. These shoes are used until the child is 5 years old. In this slide, there is a diagram available. You can easily compare the features of Ctev foot from a normal foot. The image clearly shows that the Ctev shoe has a straight inner border and outer raise, and there is no heel. So following are the references of the content of my presentation. Now, as we already discussed that what is Ctev and diagnosis, examination and the treatments available for Ctev. So at last but not least, I want to say that I have a quote of Dr. Ignatius Ponziti here, and I would like to say that your child is perfect. We only have to straighten his little feet. Thank you.